Good evening, folks. I've got discussion D for you. Now we are discussing the ACA's quiet promise and the future we kept forgetting. Okay, it's a narrative I made for you. Okay, so here we go. The story we kept missing. Every few years, America returns to the same exhausted argument about the Affordable Care Act, as if it were a single moment, a single vote, a single political symbol. But for those of us who work inside the healthcare system, the ACA is not an artifact. It is a living ecosystem. It is the scaffolding that keeps millions from falling through the cracks. And it is quietly evolving in ways the public rarely sees. Walk into any emergency department in rural Pennsylvania at 2 a.m. and you'll see the real ACA, a diabetic woman who finally got coverage for insulin, a young man whose marketplace plan is the only thing standing between him and medical bankruptcy, a grandmother whose Medicaid expansion card is the difference between preventative care and a stroke. The ACA is not perfect, but it is the closest thing we have to a national commitment that illness should not destroy a family. The annual tune-up no one talks about. Every year, the federal government releases the notice of benefit and payment parameters, NBPP, a wonky bureaucratic title for what is essentially the ACA's annual tune-up. The 2027 NBPP continues a trend that deserves more attention, tightening network accuracy, refining risks, adjustment, and pushing insurers toward simpler, more humane benefit designs. These changes matter. They determine whether a marketplace plan actually includes a cardiologist within 50 miles. They determine whether insurers are rewarded for enrolling healthy people or for caring for sick ones. They determine whether a family can understand their deductible without needing a policy degree. The NBPP is not glamorous, but it is the quiet machinery that keeps the ACA's promise alive. The basic health program, the best idea we rarely use. And then there is the basic health program, the BHP, a policy jewel tucked into section 1331 of the ACA, implemented by only 2 states and misunderstood by nearly everyone else. The BHP is simple. If you earn just above Medicaid eligibility, say a home health aide making $18,000 a year, you should not face a $150 marketplace premium. And a $7,000 deductible. You should have a plan that feels like Medicaid in affordability, but offers broader networks and more stability. That is the BHP. It is designed for the people who live on the edge of eligibility cliffs, whose income fluctuates month to month, whose coverage returns or whose coverage churns like a washing machine. It's designed for the workers who keep our long-term care facilities running, who care for our elders, who feed our children, who clean our hospitals. The BHP is not a luxury, it is a moral correction. What we refuse to admit. The ACA's greatest flaw is not structural. It is political. We treat coverage as a partisan trophy rather than a public utility. We debate the ACA as if it were an abstract ideology rather than the infrastructure that determines whether a cancer patient gets chemotherapy. Well, the system continues to evolve without us. The NBPP tightens rules to protect consumers. States quietly explore BHP feasibility. Marketplace enrollment hits record highs. Medicaid expansion continues to save rural hospitals. The ACA is not frozen. In 2010, it is growing up. A future we could choose. Imagine a country where more states adopt the basic health program, smoothing the jagged edges of affordability. Imagine a marketplace where standardized plans make coverage intuitive rather than punishing. Imagine risk adjustment models that reward care for the sick rather than selection of the healthy. Imagine networks accuracy rules adequacy rules that mean what they say. None of this requires new legislation. It requires political courage, administrative competence, and a willingness to see the ACA not as a battlefield, but as a foundation. The ACA was never meant to be the final word. It was meant to be the beginning of a national conversation about what we owe each other when illness strikes. We can still choose to continue that conversation. The quiet truth, the ACA and basic health program are not perfect, but they are proof that policy can be both technical and humane. They are proof that government can build systems that actually work. They are proof that coverage is not charity, it is infrastructure. And in a country where illness is inevitable, but bankruptcy should not be, they remain our best chance. They remain our best chance at a future where health is not a privilege. Here's your expanded publication ready. Okay. The next part of this, guys, is the title is the quiet crisis in home health and the reform we can no longer delay. Okay. America is aging into a system that was never built for longevity. Every week in living rooms and in farmhouses and row homes across Pennsylvania, I meet families who are doing the impossible, caring for a parent with dementia while working full time, managing complex medical needs with no training, or trying to keep a frail spouse safe at home. Because the nearest nursing home has a 6-month wait list, and they are exhausted, frightened, and often ashamed, not because they have failed, but because our policies have. The truth is simple. Home health care is now the backbone of aging in America. Yet we fund it as if it were a luxury. We treat caregivers as disposable labor. We measure quality with outdated tools, and we pay for services with a patchwork of rules so confusing that even seasoned clinicians struggle to explain them. The latest federal payment updates, including changes to the home health prospective payment system. HHPPS, the Home Health Quality Reporting Program, HHQRP, and the expanded Home Health Value Based Purchasing, or HHVBP model, are a reminder that the system is shifting, but they are not enough. Not when the stakes are this high. The payment system is still out of step with reality. Home health agencies are being asked to do more with less, manage medically complex patients, prevent avoidable hospitalizations, support family caregivers, and deliver high quality care under increasingly tight margins. The recent HHPPS rate adjustments including behavioral offsets and case mix recalibrations may be accurately justified, but they land in a sector already strained by workforce shortages and rising acuity. Payment reform must start with a basic acknowledgement. Home health is not a cost center, it is a cost saver. Every hospitalization prevented, every fall avoided, every caregiver supported translates into downstream savings for Medicare, Medicaid. Yet we continue to underinvest in the very workforce that makes those outcomes possible. We have built a system where agencies are financially punished for saving the very patients who most need care. people with multi-morbidity, cognitive impairment, or limited family support. The result is predictable, fewer agencies willing to take higher acuity patients, more affordable hospitalizations, and families left to manage complex medical needs alone. If we want stability, we must pay for it. That means trying reimbursement to wages, enforcing pass-through requirements, and building a financing model that doesn't punish agencies for serving high-need patients. It means acknowledging that the cost of doing nothing is far higher than the cost of doing this right. Quality measurement shouldn't reflect what families actually experience. The HHQRP and HHVP programs aim to reward better outcomes, but they still rely heavily on documentation rather than lived experience. Families do not judge home health by the number of check boxes completed. They judge it by whether their mother feels safe walking into the bathroom, whether their father's pain is controlled, whether someone answers the phone at 2 a.m. We need quality measures that capture community communication, caregiver burden, and functional stability, the outcomes that matter most to people trying to remain at home. And we need digital reporting systems that reduce administrative load rather than adding to it. Right now, clinicians spend hours documenting tasks that do not meaningfully reflect the complexity of the care they provide. A nurse who spends 45 minutes calming a terrified patient with advanced dementia may have no place to record that work. A home health aide who prevents a fall by noticing subtle changes in gait may never see that skill reflected in a quality score. Quality measurement should illuminate care, not obscure it. The workforce is the reform. No payment model will succeed without a stable workforce. Home health aides personal care attendants, and visiting nurses are the quiet engine of the entire system. They are also among the lowest paid workers in healthcare. We cannot keep asking people to perform intimate, physically demanding, emotionally heavy work for wages that barely clear the poverty line. Reform must include living wages and benefits, standardized training and career ladders, portable credentials across states. Child care, transportation, and safety supports. This is not charity, it is infrastructure. When we talk about aging in place, we are really talking about the labor of women, disproportionately women of color, who hold up the system with their hands, hands and hearts. If we want a future where people can remain at home, we must invest in the workforce that makes home possible. Families are the hidden system, and they are breaking. Every policy discussion about home health should begin with a simple fact. The largest workforce in America is unpaid family caregivers. They are holding up the system with their bodies, their savings, their sleep. We need tax credits, paid family leave, respite programs, and caregiver training that is accessible, practical, and culturally competent, supporting families, not a nice to have. It is the only way to prevent collapse. Right now, families are rationing their own health to preserve the health of someone they love. They are skipping medical appointments, leaving jobs, draining retirement accounts, and sacrificing sleep. They are doing this quietly, invisibly, and at enormous personal cost. A humane society would not allow this. Aging in America should not be a punishment. We are living longer than any generation before us. That should be a triumph. Instead, it has become a source of fear of bankruptcy, fear of institutionalization, fear of becoming a burden. Home health reform is not about spreadsheets or regulatory updates. It is about dignity. It is about whether people can remain in the same place they love, surrounded by the people who love them. It is about whether we believe aging is a public responsibility or a private crisis. The policies are already The evidence is the policies. The policies are ready. The evidence is clear. What we lack is the political will to accept change. Okay, guys, so that is your D for the night. I will see everybody tomorrow for shows. Until then, Gator Wellness, take care, folks.